2-3 ಯೂನಿಟ್ ಚೀಫ್ಸ್ಗೂ ಆಯ್ತು, 5-6 ಫ್ಯಾಕಲ್ಟಿ, 7-8 PGs. ಇಲ್ಲಿ ಉಡುಪಿಯಲ್ಲಿ ಇಟ್ ಇಸ್ ಸ್ವಲ್ಪ ಹೈ ಪೊಟೆನ್ಶಿಯಲ್ ಏರಿಯಾ, 1800-600 ಆತರ.
ಕರೆಕ್ಟ್ ಸರ್, ನಮ್ಮಲ್ಲಿ ಹಾಗೆ ಆಗಿದೆ ಸರ್. ಗುಡ್ ನಂಬರ್ ಆಫ್ ಸ್ಟಾಫ್ ಅಂಡ್ ಇಂಟರ್ನ್ಸ್ ಅಂಡ್ ಔಟ್ ಸರ್ವಿಸ್.
ಸೊ ಎನಿವೇ ಇಟ್ಸ್ ಗೋಯಿಂಗ್ ಆನ್. ಎನಿವೇ CBRT ಇಲ್ಲದಿದ್ರು hope that it
just run through the slides, Dr. Irshad. Sorry sir, I'm just checking.
Yeah.
Run through the
Yes,
slides,
sir.
Irshad,
Yes, sir.
till the end. Do you have any ultrasound or pathology report, CT report, anything, ma?
No, sir. I am not having the pathology reports in USG. So I have just.
Okay. Thank you very much, ma. Just wait. Kanna sir, good evening, sir. Srinivasan sir, good evening. I could see Professor Vijay Kamath sir. Sir, most welcome, sir. I'm unable to recognize you, sir. Thank you for joining today.
Good evening, sir. Good evening.
Thank you, sir. Thank you for joining us. Can you please unshare the screen for a moment, ma?
Yes, sir.
Good evening, sir. Kanagwal, sir. Chennai,
Sir,
sir.
good evening,
Good,
sir. How is your father, sir?
Sir, better, sir, by God's grace.
Okay, sir.
Sir, Srinivasan sir.
Good evening, sir. Kanna,
Good
sir.
evening.
Namaskar.
Good evening, Khanna sir and Srinivasan.
Good evening,
Namaskar. So, sir, it looks like north is very cold.
Yes, please go.
Sir, I think, sir, can we start, sir? Kanna, sir? Good evening, friends. It's 8 o'clock. We have two important cases. One case is contributed by Professor Guru Shantapa sir and Shilpa ma'am. Both are from KIMS Hubballi. And then that's Dr. Sujit. And then we have Dr. Irshad from Dr. Ramkrishna, Sri Ramkrishna Hospital, Coimbatore. He's been waiting for some time to present a case with us. So I warmly welcome the senior faculty here, Kanna sir, Rajgopal sir, Srinivasan sir. And we have the guest faculty, Professor Somprakash Basu sir from All Day Institute of Medical Sciences, Rishikesh, who kindly accepted our invitation in a short notice. And we have our senior faculty, Professor Jailal sir, with us. And
Namaskar, Jailal sir.
guest faculty also joining today. Thank you very much, friends, for joining us. Sir, with the permission, can we have the CAP in his case first so that we can take little longer time for the abdomen case, sir?
Sir, Professor Clement sir also is there.
Sir, most welcome, sir. Clement sir, good evening, sir.
Good evening. Good evening.
Thank you for joining us this evening, sir.
Sir, Rajan sir, good evening.
Hello, sir. Good evening.
Good evening, sir.
Thank you.
Sir, Jailal sir and Khanna sir. Good evening, sir.
Very good.
Good evening, sir. Sir, how are you?
Doing well, sir. Thank you.
Irshad, you can start sharing a screen.
Yes, Dr. Irshad,
Ye-
please start sharing your screen, Irshad.
Yes, sir.
So please go ahead, Irshad. You make your screen full.
So I hope my
Faculty,
screen is
kindly
visible,
take
sir.
over. Good evening. All the best.
Yeah, thank you, sir. Good evening, sir. May I start the presentation, sir?
Yes, ma'am.
Yes, sir. Myself, Dr. Irshad. I'm DMB General Surgery postgraduate from Sri Ramakrishna Hospital, Coimbatore. I'm here to present a case of carcinoma of penis. Moving on to the presentation, it's a 55-year-old gentleman who's a Hindu by religion, hailing from Pollachi, who is a farmer by occupation, has presented with chief complaints of ulcer at the tip of the penis region for the past 3 months. Moving on to the history of presenting illness, patient was apparently asymptomatic 3 months ago, following which patient noticed a small ulcer which is around 1 centimeter in size, which is present over the tip of the penis, which is insidious in onset and has gradually progressed over 2 months, and which is rapid in progression to attain a present size of around 2 cross 2 centimeter, and is associated with dull aching pain, which is non-radiating, and it is not and it is usually relieved on medications. There is a history of minimal serious discharge from the ulcer, which is non-foul smelling and non-blood stain. There is history of dribbling of urine, which is present, and patient also complains of thinning of urinary stream and has to strain during upon urination. There is also a history of bilateral swellings, which is where the swelling on the right side is more prominent as compared to the left. Patient gives a history of high risk behavior, which is there is a history of multiple sexual partners in his past. There is no history of recent onset of phimosis or any premalignant lesions. No history of fever, preoperism, loss of weight, or loss of appetite. There is no history there is no history of hemoptysis or dyspnea. No history of jaundice. No history of bone pain. Moving on to the past medical and surgical history, patient is a known case of a diabetic and hypertensive for the past 5 years and is on medications, which is oral hypoglycemic drugs. And for hypertension, he's on calcium channel blockers. There is no history of sexually transmitted diseases in the past. No other surgeries, which is in the past. Moving on to a personal history, he's a known smoker and an alcoholic. He takes around 6 BDs per day for the past 5 years and is an occasional alcoholic. There is history of high-risk behavior, which is that has multiple sexual partners in his previous life. There is no history of any allergies pertaining to food or drugs. Moving on to the treatment history, patient came to our OP and has underwent an incisional biopsy 3 months ago, and which has came out to be a squamous cell carcinoma of penis. Moving on to the summary of the case, it's a 55-year-old gentleman who is a chronic smoker, alcoholic, with high-risk behavior in the past, is a known diabetic, hypertensive for 5 years, presented to the OPD with chief complaints of ulcer at the tip of the penis for the past 3 months, which is dull aching, associated with dull aching pain for the past 1 month, and is associated with thin urinary stream. So my provincial diagnosis would be, as the patient is an elderly patient with a chronic ulcer at the tip of the penis and associated urinary symptoms, considering the age, I would want to keep the diagnosis as a malignant ulcer and as a carcinoma of penis. Shall I continue my presentation, sir?
No, wait. You go to the first slide with the history.
Shilpa, you said there is a urinary difficulty in passing urine.
Yes.
And
sir.
also he has repeatedly, 3 times you are saying he has a maturation in sexual, multisexual disease. Do you have anything other than this carcinoma reason for this difficulty in passing urine?
Sir, we can also consider gonorrhea in this case.
Then why do you want to say there is no sexually transmitted disease?
Sir, in the past, there is no history of sexually transmitted. That is why I just put it in the past.
Normally we do not expect a carcinoma of penis to produce a difficulty in passing urine.
Yes,
Involvement of the uterus is very rare. So when you have a difficult case, because he has a bilateral hernia, that can only come for the great straining. So here is a case who have a patient who has a straining for the passing urine, and you also say it is a thinning. And do you want to still consider this a first reason as a carcinoma is the cause, or any other reason?
So considering the age of the patient, and there is a malignant ulcer which is being progressively attaining over the three months, increasing in size, I would want to keep malignant ulcer as a carcinoma of penis as my first diagnosis.
Okay. Normally, usually we will not get urinary strain difficulty in the carcinoma, and and the picture will come only late. Even if the patient has a past history, it will come late. I feel that you must keep that option open for you to think, because when you are treating also, it has a important stay on that. Because he has a bilateral inguinal hernia. In the summary, you are not mentioning that.
Sorry, sir. It was associated with bilateral inguinal swellings.
Well,
which
when
is
you are presenting this case, sometimes we may shift on to discussing on the hernia also. So you cannot leave that finding very late. And you are saying there is a pain also, dull aching pain. Why do you expect a dull aching pain there?
Sir, at the tip of the... Sir,
where is the pain? Where is the pain? And
over the ulcer site. I would want to tell, because there can be perineural involvement, which can also have pain. If it is associated with perineural involvement, it can be associated with pain.
Skeletal pain or visceral pain?
The patient has given a very vague history on pain, which he didn't associated with any swellings over the inguinal region. He said only at the tip of the penis, he would usually get a dull aching pain, which is relieved usually on NSAIDs. I have mentioned it here so that the the ulcer can have a perineural involvement, which can be painful. Usually, it is a painless ulcers, carcinoma of penis, but when there is an involvement of perineural, there can be chances of pain associated with it.
There is no involvement in the prepuce, no? There is nothing is there in the prepuce.
Prepuce is, yes, sir. Prepuce is retractable, which I have mentioned in my examination, sir. And there is also no history of circumcision in the past.
Why can't it be a chancroid?
So chancroid is a painful ulcer, but in this case, there is a rapid progression of the ulcer over the 3 months history. So I would want to keep CA penis as a first diagnosis. Yes, it can also be a chancroid.
Actually, from a history, the chancroid is better, isn't it? I mean, chancroids are acute ulcers. There's a short duration. Chancroid can give rise to associated history of urethritis or urinary tract involvement, or at the same time, it is painful. So you also mentioned that there is pain. And what are the points in favor of your thinking is malignant as a first diagnosis? What are the points in favor?
Sir,
apart from the age and short duration, which also goes against short duration.
There is also bilateral. Yes, sir. There is also bilateral inguinal swellings, which are is not associated with cough impulse. Considering all these factors,
you haven't examined them as yet, isn't it?
Okay, the patient has given a history of swelling over the inguinal region in the right side. So, considering all the factors,
you have not examined this patient as yet. You can,
yes,
as Dr. Jalal was saying, that you can consider them as inguinal hernias.
Okay.
So, from the history which you have received till now, you have received a ulcer which is of 3 months duration. He has a high risk sexual behavior. It is painful and is associated with urinary tract symptoms. So, why you want to keep it diagnosis of malignancy as a first?
Any concerns, questions?
You are saying it is only an ulcer, not an ulceroproliferative lesion or a growth.
Sir, I would want to tell it is involving the glands. So at the later stages, it has become as an ulceroproliferative lesion. So I would consider
you are not mentioning anything because you are presenting it only as an ulcer. The first possibility, ulcer, chancroid, as Sir has said, that will be when you say purely it is an ulcer. Painful ulcer.
Hello, sir.
Now, wait. Ambuja, madam, please mute.
Someone.
No, he had mentioned in the history there was an incision biopsy taken and the biopsy came as thing that he mentioned in the history itself, sir. So he's sticking on to that same diagnosis. See, sir is asking various things about the pain, the multiple sexual partners. So why don't you think in the other way? Or what are the points in justification to say it's a carcinoma penis, apart from the age and the ulcer?
Rapidly progressive ulcer over the 2 months.
Don't use the word rapid. It was 1 centimeter 3 months back. After that, it has become a 2 centimeters. So and our time is 3 months.
Sir, it is also sir, it is also associated with a foul-smelling discharge from the ulcer.
No, that is any ulcer will be producing a foul-smelling discharge, especially in the urinary tract. You will have any ulcer nearby, even if it is a chancroid ulcer or any ulcer, you will have only a foul-smelling. So that is not a very rapidly growing ulcer also.
Sir, I have thought
what. No, only thing what we want to impress upon you, so you don't just because you are now thought of a diagnosis of carcinoma penis, so you are forgetting all other side-by lesions and straight away putting on to that diagnosis. The better you go in an open-minded, think of all the possibilities and then it to go. Otherwise, it is fine.
Okay.
I
think
no. Go to this previous the risk factors and other. Go to the second slide, ba.
Yes, sir.
1 second.
Yeah, leave it.
Yes, sir.
Yeah, what Jalal sir is insisting straightway with this history. If you are putting it as a malignant lesion, you have to justify like what Srinivasan sir said, there is a history of having taken biopsy. Okay, that is a strong point in favor of suspecting malignancy. But I'm surprised in a diabetic, non-diabetic at the age of 55, why you did not bring the discussion of simple bulonoposthitis, which is a more common penile lesion which can have urinary symptoms also, and which is a benign disease and known in diabetics.
Okay. That can also be a possibility, sir.
Exactly. So what we are asking at history level, without having seen the patient, you should keep other possibilities also. Straight away, you cannot put the malignancy as the first cause. So I insist you should have put bulonoposthitis as the first cause because the patient is diabetic and 55 years and history of urinary symptom. What urinary symptoms you may expect in bulonoposthitis?
Sir, lower urinary tract symptoms like burning micturition and dysuria.
Frequency will be there.
Increased frequency of micturition.
Rather than straining at micturition.
Okay.
Straining at micturition will be more towards in favor of sexually transmitted diseases.
Sexual transmitted diseases like gonorrhea.
Okay. And both of these may not be there. Both of these may not be there in malignancy of the penis.
Okay.
So person having urinary symptoms along with a penile lesion history, keep a possibility of benign diseases first in the form of bulonoposthitis and other sexually transmitted diseases.
Okay.
So then third possibility, definitely. That's what we are insisting on at history level. Always things will sit on exam. Okay?
Okay.
Fine.
So you can go ahead, Shilpa.
So moving on to the examination of the patient, general survey after obtaining a proper consent from the patient, and the patient is examined in a well lighted room. The vitals of the patient are examined with systolic of 130 with a diastolic of 80 mmHg, which is measured in the right upper arm at the heart level. His pulse rate is around 80 beats per minute, which is normal in rhythm, normal in volume, and with no other specific characteristic of vessel walls. The patient is around 168 centimeters, and his weight is around 60 kilograms. His BMI is calculated to be around 22, with an ECOG score of 2. He is moderately built and nourished, and is adequately hydrated. There is no pallor, not ectric, no clubbing, cyanosis, or no generalized lymphadenopathy. But there is a specific lymph node involvement, which I have discussed in the local examination. There is no other bilateral pedal edema. Moving on to the local examination part.
Two things. Before going for the local examination, I mean, what do you say? It is ECOG is 2?
Sir, the patient is moderately built, but he also has.
What is ECOG 2? When will you say it is ECOG 2?
When the patient has a restriction on physical activities, increased.
What is the restriction he is having?
Sir, he says. So he says when he is climbing 2 staircases, he feels at times breathlessness. So that is why I couldn't put him under.
You said there is no respiratory symptoms in the history.
Yes, so there is no.
Now, but suddenly you don't bring in. See, absolutely no. ECOG 2 cannot be accepted for this case.
Okay.
Don't try to add just because patient comes to you. Do not put other factors into that, and that means that exposes you. You are not studied on the ECOG or the Carcinoma score, and even if you're not mentioning, you don't mind. But when you are mentioning it, you have to mention it very properly. Absolutely, this patient cannot come to the ECOG 2. Go ahead.
Okay. On moving to the local examination,
please repeatedly again, we are saying don't use the word local examination. What you are going to examine, you have to mention.
Okay.
This is one of the standard teaching which we are teaching in this PG clinic, that never use the word local examination. Examination of the external genitalia, external of the internal scrotal region. So that heading you have to always put.
Okay, sir. On inspection, after retracting the prepuce, an ulcer-proliferative growth of 2 × 2 centimeters in the ventral surface of the glans penis, which is extending 1 centimeter from the coronal sulcus proximally. These edges are raised and is everted. Margins are irregular. There is a whitish patch which is seen on the floor of the ulcer. Urinary meatus seems to be associated with some amount of serous discharge. On moving to palpation, after confirming all the inspected findings, except the size, which is measured to around 2.5 × 2.5 centimeter, the induration is present till the mid-shaft region of the penis. Moving to the examination of the other external genital regions like scrotum, there is no warmth and tenderness. There are normal scrotal skin rugal folds are seen. Bilateral testis is palpable. Cord structures are palpable. On moving to specific inguinal node examination, on the right side, there is a vague swelling of 3 × 3 centimeter, which is mobile, single, and non-tender, non-mated, firm nodes, which are seen in the superficial inguinal region. And the skin over the region is normal. On moving to the left side, there is a single 2 × 2 centimeters firm, mobile, non-tender, non-mated lymph nodes without any skin changes with normal skin. Moving on to other system examination. On moving to cardiovascular system examination, patient has a normal S1 and S2. On respiratory system, there is a bilateral air entry is equal on both the sides. There is no focal neurological deficit seen on central nervous system. And on digital rectal examination, perianal skin is normal. Sphincter tone appears to be normal, and there is no significant pathology seen.
50 members.
Moving to the summary of the case,
on the food
the 55-year-old gentleman who is a farmer by occupation, is a Hindu, is a chronic smoker and an alcoholic, known case of diabetic hypertensive, hailing from Coimbatore, has presented with a small ulcer in the tip of the penis, which is rapidly progressive to attain the present size, and is associated with dull, aching pain and thinning of urinary stream, which is present for past 3 months, associated with bilateral inguinal swelling, right more than the left. On examination, patient is moderately nourished with an ECOG score of 1, BMI of 23, and with an ulcerative proliferative growth with raised everted edges in the ventral aspect extending proximally up to 1 centimeter of coronal sulcus with induration up to mid shaft of penis, with bilateral non-mated, non-tender and firm nodes with normal urinary meatus on examination. Hence, I would want to conclude the diagnosis of this patient being a carcinoma of penis.
You 2-3 things, and one is on the examination of the node, and you are saying it is a vague node, but you are saying it is a firm node, non-tender, mobile. Sir, and why do you want to put this at a vague node?
So it's a single node. Sorry, sir, vague. I should not have put.
You said a single node, but you said non-mated.
Why for a single node?
Sorry, sir, I should not have used the non-mated. It's a single 3 × 3 centimeter, mobile, non-tender, firm node.
Are you able to see corona and sulcus also? Perpetual end, always this thing you are able to retract?
Yes, the on retracting the, yes.
The picture it was showing, it is, you are not able to see it. Okay, if it is seen, it's fine. But here it is not. It looks like it is non-retractable.
Sir, when we are able to retract, I was the involvement of the prepusal region was able to be seen. So I mean, coronal sulcus was able to be seen. That's why I have mentioned it.
So your induration is much. I mean, in the shaft it goes.
The induration is till the mid shaft region.
So what does it indicate?
Sir, it indicates the involvement of corporal involvement. So in this case,
what is the relationship of induration and corporal involvement?
Sir, it indicates that the lesion is it can be high with increased depth lesion, so it can be more than T1B lesion.
So with the induration, you are making a lesion.
So more likely to be, but still with the primary cannot conclude. So I would want to go for an investigations to conclude.
Why not that induration is due to the infection?
So
why not that induration is due to the infection?
Sir, it can also be due to the infection, but looking on the other factors, considering malignancy as an option, I would want to confirm it with the investigations.
Irshad?
Yes, sir.
Yeah, I wanted two clarifications. Is corona glandis is seen all around?
Sir, it was seen only over the ventral aspect. On the dorsal aspect, it was not able to be appreciated. Sir.
Okay. is any part of the gland seen, or is it occupied with a tumor or the proliferative lesion?
So the glans is completely this. It is completely destructed. It is also proliferative lesion involving more than half of the glands.
Means part of the gland is seen.
Yes, sir. Posterior part of the glans is seen.
Okay.
Irshad, I have one question to you.
Yes, sir.
Did you observe the patient while passing urine? Generally, we don't do it, but I just want to ask, in your case, if so, why?
So in case of urethral involvement, there can be the stream of the urine can be affected, but there can be thinning of stream, and the patient would have dribbling sensation.
No. The reason, see, dribbling. You are repeatedly using the word dribbling. There's a difference between dribbling or bifid stream. Bifid stream means, when you observe if there's a urethral fistula.
Okay.
So there is a possibility patient will tell urine is also coming from another side. So even if we are not able to identify the external urinary meatus, ask the patient where exactly is the meatus. You understand? So that's how you need to identify
the urine. Okay.
When you are presented, there is a vague swelling, and why not? It is an internal hernia.
Sir, from the history, it was not associated with any cough, and it is the patient didn't give a history of reducibility or associated with cough.
All that is not there. When you are examining, that you have already said there is a hernia, bilateral hernia in the history. When you are presenting on inspection or palpation, you are not mentioning anything about. But you are only saying there is a vague swelling, single vague swelling. And I'm asking that, how do you say that vague swelling is not known?
I test for the fish and
sir, that's why on examination, the swelling was examined and it didn't have any associated with cough impulse. I didn't mention in the...
You should mention. You are presenting the case,
and
that means you must mention that also.
I have said it, sir, but I didn't mention, sir. I'm sorry, sir.
Did you do a rectal examination?
Sir, yes, a digital rectal examination was done.
What was the need for doing it?
Sir, in case of CA penis, there can be involvement of pelvic nodes or prostate involvement can be seen, sir. But in my case, in digital rectal examination, there is no any added deformity. Sphincter tone appears to be normal, and there is no obvious prostate enlargements.
So one is that you try to find out whether it is a T4 tumor, right? So
yes, a T4 with involvement of adjacent structures.
With the patient with a history of dribbling, poor stream, so can it also be because of the benign prostatic hyperplasia? 55
so
years, more than 40, yeah.
So I can't hear, sir. Hello, sir.
I am saying that a patient beyond 50 years with presence of urinary stream, poor stream, dribbling. So don't you think you also should rule out a benign prostatic hyperplasia also in this patient?
Sir, because in this case, his main complaint was also proliferative lesion, which is associated with the other thing of stream of urine. So that is why I have considered this as the first.
Don't do the examination with the diagnosis. Do the examination, then we come to a diagnosis. So you are not mentioned about the prostate. Okay.
Patient.
You need to do that. Do you understand? What is the point?
Yes,
the point is, till now what you have presented, the whole focus has gone towards the carcinoma penis, carcinoma penis, carcinoma penis, carcinoma penis. You're not keeping a very open mind. You are sitting in the OPD to see a patient, and the patient comes with a disease. You have to see the whole perspective of that. You have to first make a differential diagnosis. You have to attend to all the symptoms the patient has. So if you have a urinary tract symptom, it can be so many things which are you're forcibly attributing the carcinoma penis only to the urinary tract symptom, which is very rare and not very early also. It happens in a very late stage of the disease. And when you do a clinical examination, it is mandatory that you must do a rectal examination, mention that the prostate and seminal vesicles are not involved.
No.
Because it's an advanced disease. According to you, the whole shaft, almost quite an extent of the shaft is indurated. So that's a part of your clinical examination, not saying that it is unremarkable, because that means it means that you are not sure what you are looking for. The whole idea is that you have to show that you have taken all these things into consideration, right?
Okay.
Yeah, please.
Yeah.
You are saying that urinary, is it has any role on the staging or any treatment protocol?
Sir, if there is a urethral involvement, the stage is being upgraded to T3, where there can be involvement of urethra. So T3 or more lesion.
You must learn when you are presenting a case. Please treat HCC 8 staging, and then only you must come to your conclusion. No, please don't. These are the basic thing, and if you are you should not make a mistake on this. So both in T2 and T3, with or without.
There can be with or without involvement.
And how do you say the urethral involvement will be increasing?
Okay, sir. I just wanted to tell it is more than T1B, or it is more than a high grade lesion. So I would, which will affect the.
You can't say high grade lesion. It is a high grade lesion. It takes into the either it's a lymphovascular involvement or the histological grading. So that only we are going to say. We are clinically we are not going to say that. Your level is only going to say whether it is a T1, T1A and B also you will not be able to say, because it is a lymphovascular involvement and the perineural involvement has to be there in the part.
Okay.
So what is possible within your clinical examination only, the staging has to be done. Your rectal examination and identifying whether the seminal vesicle is involved or if there is a prostatic involvement of the pelvic bone, that only makes it to T4 lesion.
Okay.
Irshad, one more thing, what I heard you say is that you wanted to do a rectal examination to examine the pelvic nodes. Is that I heard, right?
Yeah. Yes.
Okay, how do you do a rectal? How do you find out pelvic nodes from rectal examination? Because that you mentioned first instead of the prostate.
Yes,
you actually palpate the pelvic nodes through rectal examination?
No, ma'am. If it is enlarged and if it is in a thin individual, it can be palpated. The most commonly we see the prostate involvement.
You cannot palpate pelvic nodes if you are wrongly informed, Irshad. You cannot palpate. You have to palpate. Instead, you give more importance to examination of the urethra. You didn't mention examination of the urethra.
Okay, joints.
Okay, so it is not. You cannot palpate pelvic nodes through rectum.
Okay. Okay.
Is there any picture?
There is no evidence of strictures here. Also,
where do you examine for stricture? How do you examine?
So we examine the posterior urethra, the bulbar urethra, by elevating the scrotum, and if there is a stricture, there is a cord-like structure which can be palpable, which is not evident in this case. That is how I want to tell that there is no involvement of stricture urethra.
Okay, Ishad, please switch on your video, Dr. Ishad.
Yes.
So how you are going to proceed?
Sir, in this case, I would want to confirm the diagnosis of this patient. So I would, as already from the past with incisional biopsy, it is confirmed to be a squamous cell carcinoma. I would want to do a staging workup of this patient.
No, you just want to have it is a squamous cell carcinoma or anything. What do you expect from the pathologist to give you the report?
So in the pathology report, I would want to know the grading of the tumor, whether it is a well differentiated, poorly differentiated or not. If it is with keratin pearl, then it is well differentiated tumor. It has a very good prognosis. And I would want to also go for staging workup. I would want to do an ultrasound, which is an extension, to look for corporal involvement. And then I would want to further do an MRI where induration can be, involvement of corpus in cavernosum and spongiosum involvement can be delineated. I would also want to do a CECT abdomen in this case to look for lymph nodes.
So you don't use ultrasound to look for the lymph node?
Sir, ultrasound can also be used if it is not correctly as this patient has an right inguinal lymph node as well. I would want to also rule out other intra-abdominal
what
lesions.
Group of lymph node? Is it a vertical group or a horizontal group?
So it is a superficial node, which is horizontal group of nodes were involved.
What is the commonly involved node? How will you divide the superficial nodes?
Superficial nodes which are above the tensor fascial lata, which is between the scarpa's fascia and the tensor fascial lata.
No, you are aware whether it's a superior-medial, inferior-medial, superior-lateral, central group?
Sir, it is a superior medial group of nodes, vertical group of horizontal group of nodes.
Opposite side, left side also,
Sir,
bilateral node.
Yes, bilateral nodes were there. On the bilateral side, on the other side, that is on the left side as well, there is a 2 × 2 centimeter node, which is from.
Can an ultrasound tell you whether this node is a malignant node or a benign node?
Yes, sir. In ultrasound, the features include a loss of fatty hilum, firm node. Other signs of node is a malignant.
Shape of the node.
Shape of the node. I would now want to proceed with the staging workup. I would want to do a chest X-ray, and yes, sir.
No, this case is when we are talking about ultrasound, you must include many things in that. You are not only saying whether confirms your diagnosis, but because we have a question in doubt on the hernia, a question on doubt on the prostate. So all these things that you have to see. You don't jump from one to then straight away say just for the sake of that, going to the MRI, going to the PET scan. All those is not needed. No? If you have a good ultrasound, you must include all those findings what you are going to look for when you are taking the case. I mean, abdomen also you will have.
Okay.
So now you want to do the metastatic workup.
Yes, sir. I would want to do a metastatic workup. So I go for a chest X-ray to look for chest lesions, and I would go for a CBCT abdomen to look for other intra-abdominal organs. And also I would want to, as the lymph node is involved, I would want to go for an FNAC of the node to confirm whether it is the whether it is a lymphovascular lymph node involvement due to the primary at the carcinoma of penis. From this, we conclude that it is a case of a CA penis with the grading from the histology of whether it is well differentiated, poorly differentiated or not. In this case, as a part of treatment, I would want to go with a partial amputation with margins being no tumor or no ink region. And I would also want to go for a bilateral inguinal lymph node dissections. Hello, sir. Hello, sir.
How do you decide that you can go with a partial amputation?
Hello, sir. Yeah.
How do you decide that you can go ahead and do a partial amputation?
Sir, I'm not able. Your voice is breaking, sir. Kindly, I'm not able to hear, sir. Hello, sir.
Sir is asking you. Can you hear me?
Yes, sir. Yes,
yeah,
ma'am.
He's asking you, how do you decide for a partial amputation of the penis?
Ma'am, based on the histology, and if it comes to be more than T1B, and if it's a T2 lesion, and based on the mid shaft involvement, we have to leave a margin of around 2 centimeter for the stump. But ideally, no tumor, no ink is the thing for deciding the margins. With that, I would want to conclude it's a partial amputation, as it also involves only the glands of the penis and prepusal involvement is not evident. I would want to go for a partial amputation of the penis.
Right about the
Hello, sir.
Yeah, am I audible?
Hello, sir.
When you are doing an MRI of the penis, and what position or what precautions you will take to take MRI?
artificial erection has to be done during an MRA to look for complete corporal involvement. That is the one precaution we have to take. So.
Is there any role of sentinel node biopsy?
Sir, in this patient, already there is the involvement of lymph node, which is palpable. I don't want to go for a sentinel node biopsy in this case. Sir. As it is a palpable, so I. Sir?
Yeah.
Yes, sir.
Suppose the FNSC of the lymph node comes as negative. What do you do?
Sir, if the FNAC is negative, I would want to go for a trial of antibiotics for 2 weeks. Then I would want to repeat the FNAC, sir. If it repeat the FNAC after 2 weeks of trial of antibiotics. As a part of
why want to repeat the FNAC after antibiotics?
Sir, if in this case, if it is due to an infectious etiology, there can be regression can be seen. So
that's okay, but why you want to repeat the FNAC then? If it is non-malignant, will it become positive after antibiotic?
If it is regressing, to do anything.
If it is regressing, we don't have to do a repeat FNAC. But if it is still not regressing,
what does the guidelines say about the lymph node assessment? If you get a negative, the size of the lymph node vis-a-vis negative cytology, what does the guideline say?
Sir, if it is more than, I'm not sure about the size. If it's more than 3 centimeters, then more than 4 centimeters, we have to go for.
If it is negative, you have to do a biopsy. Take out the lymph node and do a biopsy.
Lymph node excision biopsy.
Especially if the lesion is more than T1.
T1.
Okay. So even the negative FNAC does not rule out malignancy for a large lymph node. Why? Because there can be sampling errors.
Okay.
So in presence of a high risk population, especially more than 1 lymph node or fixed lymph node, large lymph node, if the FNAC is negative, you have to go for the next stage is you have to go for a excision biopsy. You have to do a lymph node excision and subject it to biopsy.
Okay.
It's always T1 lesion has a very large 16%, but if it is a T2 lesion, you are having nearly 70% will have the node positive.
Node positive.
Always you are justified in going for that biopsy.
Excision biopsy.
Does differentiation of the tumor, whether it is well differentiated, poorly differentiated, does that depend on to what extent of surgery you do for the penis? You still want to go ahead with the partial amputation if it's poorly differentiated?
Ma'am, well differentiated tumors have a good prognosis, but if it's a poorly differentiated,
my question is different.
Yes, ma'am. It has a bearing. Yes, ma'am. It has a prognosis because in case of poorly differentiated.
No, I'm not asking about prognosis, Irshad. I'm asking you whether you said partial amputation, no, for this patient.
Yes.
What if your biopsy comes as poorly differentiated squamous carcinoma? You still want to go ahead with the partial amputation?
I would add on with a neoadjuvant chemotherapy and partial amputation, then an adjuvant chemotherapy. The neoadjuvant would be, I would want to go for cisplatin, ifosfamide, and
What is TIP?
Cisplatin, paclitaxel. Sorry.
Paclitaxel.
Okay. So I will go for a neoadjuvant chemotherapy followed by partial amputation with bilateral inguinal block dissection. Then I'll again go for adjuvant chemotherapy as well.
When will you actually look for or dissect the pelvic lymph nodes?
Sir, in this case, preoperatively, we have taken an FNAC and it has come to be positive. So in this case, I would want to go for a inguinal block dissection, deep inguinal dissection.
If a single
try to answer the question.
what are the indications when you proceed for a pelvic lymph node excision also in this patient?
You have done an FNAC, it's FNAC positive. Now you are going for that, you are doing a superficial laminectomy. Then will you go for ilioinguinal or pelvic? To go for pelvic, what is the indication? What is the criteria?
Sorry, sir, I'm not sure about that.
If there is one node is positive, you can go for a inguinal or ilioinguinal lymphodectomy. So if that is more than 3 nodes positive, more than 3 centimeters, more than you have extra nodal, then only you must go for a
pelvic dissection.
Okay. Two or more lymph nodes. Two or more lymph nodes, you have to go for a pelvic lymph node dissection, right?
Okay.
Can you get a pelvic node without the inguinal node? Can you get a pelvic node without inguinal nodes? Inguinal node is negative. Inguinal region is non-node. But can you get node in the pelvic region?
No, sir, because usually the lymphatic drainage is through the inguinal nodes and the pelvic nodes, but there can also be a possibility of skip lesions. But I'm not sure about that.
From the glands, you can directly go to the cloacat lymph node. Once you get the cloacat lymph node, from there you can go to the pelvic. There's no, you can bypass it. Usually it will not happen, but you can get that bypass.
What do you understand by modified inguinal lymph node, pelvic lymph node dissection?
Sorry, sir, I have not read about modified.
You know what is Dresler's quadrangle?
Yes, sir. The Dresler's quadrangle is a vertical and horizontal line drawn through the fossa ovalis, which involves
the full template. That is full template lymphadenectomy. What is modified template lymphadenectomy? Catalona's modification.
Sorry, ma'am, I'm not sure about the Catalona.
So you are not gone into the lymph node, lymphadenectomy part.
Sir, I'm not sure about the lymphadenectomy.
So whenever you are presenting a carcinoma penis case or a melanoma case, please study well with the lymphadenectomy. So that definitely some questions will be on the lymph node and what is the complication? How do you prevent that complication? What steps you take? What are the complications of lymphadenectomy?
Okay.
If you don't treat the case, what will happen?
Sir, there can be chances of lymph node involvement, and it can cause erosion of femoral artery, and there can be death due to femoral blowout.
What is the normal anatomy structure of a penis? What are the layers you have?
Sir, parts of layers of penis.
Yeah.
Skin, dartus, skin, dartus.
We are not asking for the scrotum. We are asking for the penis.
Sir, penis consists of the glans penis, prepusal, and corpus.
Layers. We have to go by layer, superficial to deep. What you have. You are right in saying skin, but what next?
Subepithelial connective tissue, and below which will be a corporal muscles, which are corpus spongiosum and cavernosum. Spongiosum consists urethra.
So you are not studied about what is tunica albuginea, what is Buck's fascia, what is superficial metaphasia. All that you are not studied. Okay.
Okay, what's the importance of Buck's fascia, Rishad? Now that we're coming to anatomy. Look, as a surgeon, you got to be very sure of your anatomy. What's the importance of Buck's fascia?
Breach in Buck's fascia can cause an extensive involvement of metastasis. So it is an anatomical barrier for the tumor cells to be confined.
Always try to answer the question now, okay? Because we repeatedly, this PG clinic is main purpose of us is to make you to learn how to answer. Don't circumvent the question. Very directly asked what is Buck's fascia, and you must answer that. Otherwise, you say no, and we'll be able to teach you. But going behind and side, it will not be a good attitude.
Okay, sorry, sir, I'm not clear about it.
So then it is become a very simple undergraduate case like things. You are not read about anything other than penis, carcinoma of the hernia and other things. You are not interested to talk about the lymphadenectomy. You are not interested to talk about the anatomy. So what area of the question you want us to ask?
Sorry, sir. I didn't read through the lymphadenectomy deeply, sir. I just read only superficial and keeping my ileoblock dissections.
What is the physiology? What is the nerve for the ejection? What is the nerve for the what is nerve for the erection? And what is nerve for ejaculation?
So for ejaculation, it is nervi erigentis.
Nervi erigentis. What is that nervi erigentis? Parasympathetic or sympathetic?
Nervi erigentis is sympathetic, sir. So, sir, I'm sorry, sir. I'm not sure about
physiology. So anatomy, physiology, pathology, no. Only on that. Suppose you are doing what is T4 lesion?
Sir, T4 lesion is involvement of adjacent structures, which includes prostate, scrotum.
So suppose the urethra is adhered to the pubic. How will you do what we are doing? Going for a total penectomy, and where do you keep the urethra? You are not able to separate the urethra from the pubic.
So we go for perineal urethrostomy. If there
only
is
when you are able to separate, you can bring it to the perineal urethrostomy.
If not separated, can go for internal diversion.
You are operating for a malignancy. Okay. What is the complication of perineal urethrostomy?
Yes. Urinary meatus stenosis, sir, in a late date.
Meatus stenosis.
Irshad?
Yes, sir.
Yeah, you have chosen partial penectomy for the primary in this case.
Yes, sir.
Yeah, you just let me know what are the grounds or what are the criteria on which you will decide for partial penectomy. On what grounds, on what factors you will decide that yes, partial penectomy is the treatment.
Sir, based on the involvement of the ulcer, whether it is ulcer proliferative or not, based on the induration, and histology.
That is how you diagnose CA. So you should tell us what extent that becomes an indication for partial. If, for example, if it is involving only the glands, tip of the glands, if it is not involving corona glandis, if it is involving to what extent? So what are the factors on which you will decide it is a case for partial penectomy?
Sir, if it is involving glands with mid-shaft up to mid-shaft region, we can decide on partial penectomy as an organ preserving strategy.
Oh, mid-shaft also you can. What is the ground?
Ideal stump.
Normal penis, the proximal normal penis. So what should be the size of the proximal normal penis?
Sir, ideal stump should be maintained at 2 centimeters for micturition to be occurring post surgery.
And what should be the margin from the tumor? What should be the margin from the tumor where you will plan for partial penectomy?
So the tumor margin is up to 5 to 10 mm can be given. It is or a new tumor, no ink margin is the ideal thing to decide on. So up to 5 mm can be the margins.
From the point of induration. It is
induration,
not the tumor margin. Induration. Okay. It is 1.5 to 2 centimeter and a minimum of 2.5 centimeter of the stump. In the sense, otherwise it has to be around 4 to 5 centimeter from the point of induration. That should be the normal penis. Why is that 2.5 centimeter normal proximal stump?
Sir, post surgery for a purpose of urination and the stream will pass. So that is why we keep 2 centimeters of stump length.
Okay.
Can I make a comment?
Yes. Sir.
Yeah, please.
I'm Professor Majid Chaudhry from Lahore.
Yes, sir.
Beautiful presentation by this young man. I'm very impressed. And, I wonder if the seniors could make a comment that what's the incidence of penile cancer in various parts of India? because, I have been doing surgery at Mayo Hospital, Lahore for the last 40 years. And I have seen only one case, would you believe that? And I was just wondering what's the incidence, and full marks to this young man. I joined late. I couldn't gather the name, but I think this young man has a brilliant future. Well done. Just some comment from the seniors.
Thank you, sir.
His name is Irshad, sir. Irshad.
Kanna sir, Rajgopal sir.
Yeah, sir, just I don't know whether to answer Dr. Majid Chowdhury's question. Is it correct?
Please, sir.
Sir, I believe it is quite common in the South Indian population. That too, I was told that it's more in Pondicherry. My professor used to tell once upon a time, but I believe in of late. Of late means in the last 2 decades, the incidence has come. I cannot give a correct incidence, sir. Maybe Jailal should be able to give a correct incidence in the locality or whatever it is. But definitely, I have seen many cases in early 90s, but in the last 10-20 years, even in the urology department, their cases have come down in our area. Yes.
You are true, sir. Absolutely, the cases are coming down, but not like that 40 years, one case. But here we have reasonably good number of cases, sir. We see. What is the difference between Bhavans and the erythroplasia of Cowart?
Sir, these are pre-malignant lesions. Erythroplasia of Cunard is involvement of with a penile intraepithelial neoplasm involving glands, whereas if it involves a shaft, it is called as Bowen's disease.
What is that disease?
Sir?
What is that? It is a carcinoma or?
It's a carcinoma in situ involving glands is erythroplasia of Cunard. Then the carcinoma in situ lesion involving the shaft of the penis is Bowen's disease.
What is Paget's disease?
Paget's disease is also a pre-malignant lesion of penis, but
you are saying carcinoma, then you are saying it is a pre-malignant.
It's a pre-malignant. Sorry, it's a pre-malignant lesion of penis, Paget's disease. But I'm not sure if it's presentation and things I've heard as a name. That's it.
I have to say something to Irshad that one or two things, because you already mentioned squamous cell carcinoma in the beginning. So cases look to be simple, as many Professor Basu and Jailal, everyone has told. But similarities, it happens also in carcinoma tongue, because everted edge and we say squamous cell carcinoma. The question which examiner generally ask you is the differential diagnosis. Rightly asked, differential diagnosis of ulcer tongue and differential diagnosis ulcer penis. In that is a time where most of us have seen the bad sexually transmitted diseases, including chancroid. You should know the difference. Chancroid in days, LGV in weeks, and there is something called as Donovan bodies. Heard of that? Lymphogranuloma inguinal.
Lymphogranuloma.
That has got 4 to 6 weeks of incubation period. And herpes genitalis. So where the nodes are not commonly enlarged, whereas in these nodes are commonly enlarged, transmitted diseases. Induration also in penis, in the tongue, it is very, very important. That's where MRI also comes to a very great extent. And rest of the things, as Jailal has put, is you should read that the superficial inguinal block dissection, superficial, in case high-grade tumor, suspicious node, biopsy, and all, Catalona's modification. A little bit reading is required. That's all my comment.
Yes.
Is there any role of human papilloma virus here?
Sir, human papilloma virus 16, 18, 31 are the commonest risk factors for carcinoma penis.
Suppose you test positive, that you are saying that and it is testing positive, that it is a human papilloma virus is positive. Is it good or bad?
Sir, it has a bad prognosis.
That's a relatively good program.
Because it has impulse. Okay.
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 Can you name some common complications of block dissection, inguinal block dissection?
Skin flap necrosis if fat is not taken during the incision. If post inguinal block dissection, if femoral artery is left without a cover of sartorius, there can be high chances of vascular injury post surgery. Other complications like infections, and that's it.
Ishad, you're doing so much of lymph node dissection. So what is the commonest complication you come across?
Most common, 40 to 50% patients will have the complication.
Most common.
Lymphedema is one of the most common.
You put a drain inside the dissection and you keep
Seroma
on
collection.
getting.
Seroma.
What is that?
Seroma.
It's called lymphoria.
Lymphoria. So whenever you do a lymph node dissection, for example, in breast, in inguinal region, so this seroma formation, lymphoria, especially if the flap doesn't take place, it becomes a major headache, isn't it? So that's a very common complication which surgeons come across, and you must know that, and you must say that as a first thing, right? And there are various techniques to prevent flap necrosis. There's incisions you can place in such a way. Although it is very common, it is not uncommon. But that lymph part, the lymphoria, the lymphoma, the seromas, these are the things which should come ahead of. When you answer the question also, you must say the common things which you see very commonly. Okay.
Right. Can I add something, sir? Just adding on to Madam Dr. Shilpa asked you a question about lymphoria. Just want to tell you, in between we asked the modification of the inguinal block dissection. In the catalonas, just to remember quickly, you preserve the scarpa's fascia, preserve the long saphenous vein, preserve the dermis, and a good preoperative check. And giving the antibiotics is not to expect the lymph node to regress or something. It is basically to prevent the complications of the inguinal block dissection. So these are the few important things which will give a good postoperative control, apart from the incision for the block dissection. Flap necrosis avoided. Flaps also, myocutaneous flap cover. These are all the points which will help you in good drainage and prevention of lymphoria and infection. These are the two, dangerous complications.
And this is one of the very common question is also asked. It's not even not in the discussion, theoretical part also. What are the steps to prevent the lymphoria, lymphedema, which is happening or following the surgery? And now the minimally invasive surgery has also come in. So even for modified Catalona, now they go for the minimally invasive surgery and various flaps coverage to do. Any role of omental flap surgery,
No, sir. I don't know about the
Okay. There are so many things on there that prevention of lymphedema. And what advice you give, what is the precautions you when the patient discharged? Please remember, the lymphedema and lymphoma can come even after patient is going home. Long after some time also it can occur. So continuously you need to make. Always infection is one of the most common causes. So at any possible time you should see to that in the postoperative period, infection is not given, the tight bandage is not given, injections are not given at that time. So all this or the protocol which is there to prevent the lymphoria developing.
Okay.
Can I wait, sir? We can close this.
I think, sir, with the permission, do we move to the next case, sir? Okay. Dr. Ishad, do you have any questions to be clarified from the senior faculty here?
No, sir.
Any doubts?
Sir, I have a doubt on Catalona's technique. Will it be fine if you could explain the Catalona's technique?
Okay.
Hello, sir.
Yes, Dr. Ishad, go ahead. Ask the question.
Sir, I am not able to understand the part of Scarpa's fascia which is being kept over the section, which I feel I cannot able to understand. Can you please explain the modified Catlonas and the Catlonas technique per se? Hello, sir.
Yes, and that will become a pure class. You must know the full template surgery where we make a wide up to the entire quadrangle will be removed. Okay. One step on the Scarpa's fascia is what sir was meaning was when you are raising the flap, the Scarpa fascia belongs to the flap together. So you raise it properly. And posteriorly also when you are doing that. See here in the Catalona's operation, the area of dissection is very less. We don't go any dissection lateral to the femoral artery. And you are not going to cut the saphenous vein, which we normally do in the full template appendectomy. Here the saphenous vein is preserved. The dissection is not going beyond the femoral artery, lateral to femoral artery. Below fossa ovalis, we don't go. And the fascia over the muscles, and we also that we don't remove, but all the other nodes, other structures will be able to remove. So since this is a limited resection, and the area is present, we were able to prevent the lymphedema. And anatomically and doing the surgeries also, it is not a very difficult one. And if you are, it comes, you need to study it, and definitely you can do that.
Thank you, sir.
Well done, Nishad. God bless you.
Thank you.
He's joining the armed forces next month, sir. He's joining the armed forces next month. We wish him all the best.
All the best.
All the best. All the best.
Cantonment Hospital, Bangalore.
Very good.
Thank you, sir.
Now we move on to the next case. Dr. Sujit Kumar from Dr. Shilpa Ma'am's unit under the headship of Dr. Guru Shantappa sir. Dr. Sujit, please switch on your video and share your PowerPoint.
Yes, sir.
We are unable to see you, Dr. Sujit.
Sir, I switch on the video, sir.
Yes, you are fine. You are fine. Good luck to you. All the best.
Thank you, sir. Good evening, everyone. Myself, Dr. Sujit, postgraduate student from the Department of General Surgery from KIMS Hubballi, presenting a case of mass abdomen. And my HOD sir is Guru Shantappa sir, Professor and HOD Department of General Surgery, KIMS Hubballi, under the mentorship of Dr. Shilpa Ma'am, Professor and Unit Chief, Department of General Surgery, KIMS Hubballi. Coming to the case presentation, 38-year male hailing from Haveri, Karnataka, who is a farmer by occupation, came to KIMS Hubballi with the chief complaints of mass per abdomen since 2 months. History of presenting illness. Patient was apparently normal 2 months back when he had a discharge from the umbilicus and burning sensation during micturition, for which he consulted the doctor, who informed the patient about the mass in the lower abdomen. Umbilical discharge was scanty, yellowish in color, foul smelling, which subsided on oral medications. And this history of mass per abdomen, which was noticed by patient since 2 months, it was in the lower abdomen, which was around 10 cross 5 centimeters initially, which rapidly progressed to the present size of around 20 cross 15 centimeters, which was associated with pain, which was intermittent and dull-aching type. And there was no aggravating or relieving factors with respect to the pain. Patient also gives history of associated hematuria 2 months back, which was only 2 episodes, which was associated with a burning sensation, which was present throughout the stream. And after 2 episodes, he didn't had any further episodes of hematuria. And also he gives history of burning sensation during micturition, and also increase in frequency of micturition. There were no history of any other swellings in the body. There is no history of intermittent fever, night sweats, or EC fatigability. No history of vomiting or altered bowel habits. No history of passing black-colored stools. No history of jaundice. There's no history of weight loss or loss of appetite, and there's no history of trauma to the abdomen. Coming to the past history, patient is not a known case of type 2 diabetes mellitus or hypertension. There's no history of tuberculosis in the past, and a patient had a history of right inguinal hernia repair 2.5 years back. Coming to the personal history, he was a vegetarian by diet with normal appetite, and sleep was adequate, and bowel habits were regular, except that bladder habits he had increased frequency, and he was a tobacco chewer since 6 years. And family history, there's no history of malignancy among the family members. Coming to the summary of my history, 38-year-old male who is a farmer by occupation or tobacco chewer, presented with a history of rapidly progressive mass in the lower abdomen since 2 months, associated with dull aching pain with increased frequency of micturition and with no altered bowel habits. With this summary, sir, I would like to give a differential diagnosis. Since he has a urinary system complaints, I would like to think of any mass, benign mass arising from the kidney. This might be bilateral hydronephrosis, or it might be even a horseshoe kidney. Or it might be a chronic distended bladder with a distal obstruction, sir. And one more different treatment I would like to give is retroperitoneal tumor, probably compressing the bladder, leading to the urinary complaint, sir.
Did you say something on the? Did you say something on the umbilical discharge? Was there something?
Yeah, that is what we want to
ask. Yes, sir. Actually, patient had a complaint of umbilical discharge 2 months back, sir, for which he went to a hospital, sir.
And after that, how you want to correlate this umbilical discharge? Because if he 2 months back he had a history of discharge from the umbilicus to the whatever symptoms he says, to the urinary symptoms as well as the mass per abdomen. Can you correlate it?
Sir, here in this patient, it has subsided on oral medications, ma'am. So it might be a simple infection of the umbilicus.
Did you ask for the detailed thing of the discharge? How was the discharge? Did you go into the detail of the discharge?
Ma'am, he said it was scanty in amount. It was once or twice in a day. It was yellowish in color, and it was foul smelling also, ma'am. So probably a purulent discharge, ma'am.
So can you correlate now that there is an umbilical discharge, there is urinary symptom, and there is a lump in the lower abdomen?
Sir, I would like to think of probably urachal cyst, sir.
Urachal?
Cyst, sir.
Fistula. Yep.
Cyst, sir. Cyst, sorry.
Cyst. Why not? It's a fistula. Okay, urachal sinus. Or
but the mass is here. Mass doesn't correlate with the presence of fistula or the sinus.
As long as there was a discharge, there is a sinus discharge. Now you say the discharge is stopped. Probably it has gone for a stricture or the close. So the mass is going on increasing in size. Is that a possibility? Oh no! Suddenly you are going for a horseshoe-shaped kidney, but since we have an umbilical discharge,
yes,
we'd like to have a correlation with that. Second possibility is only 38 years old. You are not said anything about his family, and suddenly you are bringing a retroperitoneal tumor of the cause. And could be anything on the testis? You are not said anything about his family, whether he has completed family, has a child.
Sorry, sir. He's married. He's married with 2 children, sir.
So bringing it retroperitoneal carcinoma, I mean, related to the urinary tract infection, you must also think of possibility something on the scrotum, testis. Should be also in the history should be mentioned about that.
Yes, sir.
Sujit, can you give a differential diagnosis of discharge from umbilicus with a lump in the lower abdomen. Differential diagnosis of a combination of this.
One, I think urachal cyst, sir.
Yes, one is a urachal cyst. Yes.
Yes, sir. And probably malignancy of the colon, sir, with fistula.
Okay. Any other congenital anomaly which can be there? We can present with umbilical discharge along with a lump in that area. One you said the urachal cyst.
Sir,
do you know any other congenital anomaly related to the umbilicus?
Sir, persistent vitreointestinal duct, sir.
Yes, that can also present as a lump in that area along with the discharge.
Yes, sir.
Okay. Any other one you said the sigmoid carcinoma? Any other inflammatory pathology which can present like that? Chronic inflammatory pathology?
Tuberculosis, sir.
Yes, tuberculosis can be differential. So, in fact, keeping a
Sujit?
Sorry,
Sujit,
sir. Yes, sir. Yes, sir.
I have one question to you.
Yes, sir.
One is about the discharge. One is about the discharge,
yes,
which you said subsided.
Yes,
So
sir.
if we believe that, what do you think it probably is due to?
Sorry, probably simple ampulitis, sir.
Probably. Okay, we'll
Yes,
keep it that way. Now the question is, the mass has increased from 10/5 into 20/15 over 2 months, correct?
Yes, sir. Yes, sir.
And with this strong 2 hematuria urinary complaints.
Yes, sir.
Tell me how to connect this. If you tell horseshoe kidney, it will not be accepted in the examination.
Okay.
Let me tell you something.
Yes,
Number 2, if you tell hydronephrosis, again, it will not be accepted in the examination. What I am trying to tell is, don't go by what ultrasound report or CT scan report or whatever you may know or you may not know. It's a different thing. But I want you to understand such a rapid increase in the size of the lump with the hematuria that is continuous, present throughout the stream.
Yes, sir.
So why don't you suspect a bladder malignancy? This is my question to you. Large one. I want to ask that question. You said
So,
hematuria,
yes,
burning maturation, increased frequency is there. So rather, instead of trying to put it on hydronephrosis and how to explain hydronephrosis with hematuria?
So probably ureteric calculi, sir.
Does he ever give, how ureteric calculus present with?
Sir, acute abdomen.
If anyone has suffered ureteric colic, you will understand that. So that is, do you seriously consider that?
No, sir. No,
Only
sir.
giving a differential diagnosis to
Yes,
say hydronephrosis. Hydronephrosis, where do you get the mass?
Sir, in the lumbar region.
Where is your case says?
Sir, it's lower abdomen, mostly on the right side and in the suprapubic regions.
So you are talking about the suprapubic region and the right side, which you are not mentioned is the right side. Patient has a strong urinary complaints, right?
Yes,
so you need to consider that something related to bladder, one possibility. Suppose you said it's a foul odor.
Yes, sir.
Foul odor. Any other, you said sometimes in the colon, I agree there are no bowel symptoms. Suppose
yes,
what colonic malignancy can produce umbilical fistula also, and it can erode into bladder also. Which organ can come there? Colon.
Rectum, sir.
No. Rectum is not mobile, na? What other?
Sorry, sigmoid, sir.
Sigmoid. You can have a colovesical fistula. You can also come to the umbilical surface and give a foul odor, but it will be persistent. I just want you to understand, think in that direction. And so these are my few observations. That's all.
Yes, sir.
Loss of appetite, loss of weight?
So there was no loss of appetite or loss of weight, sir. Sir.
Sir is very absolutely is right when he was asking that question. When you have said hematuria throughout the stream.
Yes,
so if
sir.
it is a hydronephrosis, if it is a calcium, you will never get that throughout the stream. No?
Yes, sir. Sir,
something more.
But he had only 2 episodes, sir. After that, he didn't had any episodes. That's one thing I didn't think of bladder mass, sir.
Oh, everything is happening in a 2 months time.
Yes, sir.
Oh, sorry, I understood that somehow I thought it's a continuous 2 months every day. Is okay.
No, sir. No, sir.
Sujit?
Yes, ma'am.
Now, you say that the patient went to a local doctor and he noticed the tumor.
Yes, ma'am.
Okay, and then it has been progressively increased from 10 to 20 centimeters. So could there be a possibility that the tumor is there since quite some time now?
Definitely, ma'am.
Yeah. So you made a diagnosis in your provisional differential diagnosis as a retroperitoneal tumor.
Yes,
so tell me why you made that diagnosis of a retroperitoneal tumor and how do you correlate with the symptoms of bladder you have?
One thing, it is a painless, asymptomatic mass, ma'am, with no bowel habits. No altered bowel habits. And
so you mean to say a retroperitoneal tumor can be a symptomatic mass for quite some time?
Yes, ma'am.
Then how do you contemplate for the bladder symptoms?
Ma'am, because it has grown to such a huge size, probably compressing the bladder, ma'am.
Compressing or what? It could be an infiltration into the bladder?
Probably, ma'am.
If there is any possibility, it's like a lymph cyst or a cystic lesion of the mesentery that is presenting like this?
Cystic lesion in the mesentery, sir. Such a huge, such a large mass, it's unlikely, sir, and rapid progression.
Okay, go ahead.
Shall I continue with the examination, sir?
Examination, go to examination.
Coming to the general physical examination, patient was examined with due consent and well-lit room. On examination, patient is moderately built and nourished. He was conscious and oriented. Vitals were pulse rate was 80 beats per minute in right radial artery, and blood pressure was 120 by 70 mm of Hg in right brachial artery, and saturation was 97% at room measure. And then respiratory rate was 18 cycles per minute, and he was afebrile at the time of examination. There was no pallor or icterus, and there was no generalized lymphadenopathy, and there was no lower limb edema or dilated veins in the lower limbs. And his ECOG performance status was grade 0. Coming to the perabdominal examination, coming to the
in the local examination,
yes, ma'am.
Considering the fact that it is a lower abdominal mass and a
yes,
huge mass,
yes,
what are the particular things you want to highlight in the general physical examination?
Ma'am, one thing, since it's a lower abdominal mass, I would like to see, as I said, the lower limb edema, ma'am, probably compressing the iliac vessels, and then even the dilated veins in the lower limbs, ma'am. One thing, and
what is the dilated veins in the lower limb called?
Ma'am, varicose veins.
Okay. Anything else?
And then with the probably a rapidly progressive mass, I would like to think of even anemia, but there is no pallor in this patient.
Anything else?
I would like to examine even the pulsations in the lower limbs, ma'am.
Anything else? You've mentioned You mentioned it as a passing comment, but you should specifically, if there is a lower abdominal mass, you should look for these three or four things. Anything else you want to find as a differential diagnosis for a rapidly progressing lower mass?
As I mentioned, generalized lymphadenopathy. So I should have looked.
Where do you want to look for lymph nodes?
Inguinal, and then axillary, and also cervical.
So you want to give as a differential, anything else as a differential diagnosis for a lower abdominal mass apart from the bladder symptoms?
Probably lymphoma.
You should keep in mind of a lymphoma also.
Yes, ma'am.
Okay. Proceed.
Coming to the perabdominal examination, on inspection, these are clinical photographs. The umbilicus was central, inverted, appears to be displaced upwards. There's no sinus opening within the umbilicus or any active discharge. There was a fullness noted in the lower abdomen involving the right iliac fossa, the hypogastrium, the left iliac fossa, the umbilical region, and both the right and left lumbar region. There was a scar of around 6 centimeters obliquely placed in the right inguinal region, which was healed by primary intention. And there was also a scar of around 0.5 centimeters in the right iliac fossa, which was around 4 centimeters medial and above to the right anterior iliac spine, which was healed by primary intention. Right flank appears full, and left flank is free. Hernial orifices appears intact. External genitalia appears normal. On leg raising test, there was no change in the fullness of the fullness noted. Coming to the palpation, there's a mass of a palpable mass of size 20 cross 15 centimeters, which was occupying right iliac fossa, hypogastrium, left iliac fossa, umbilical, right and left lumbar region, extending superiorly 1 centimeter above the umbilicus. On right side, extending up to the right anterior axillary line. Left side, on the left side, it was 3 centimeters short of the left and anterior axillary line. And superior border was well made out, but inferior border could not be made out. Surface was smooth and mass was non-tender, and mass had a restricted mobility horizontally, and it was hard in consistency. This was the boundaries of the mass which I palpated. And there is a small short video of palpation. In this video, I was trying to initiate my fingers within the iliac bones, which I couldn't do on the right side. So there was I couldn't make out the lower border of the mass. Continuing with the palpation of the perabdomen, rest of the abdomen was soft and non-tender. There's no hepatomegaly. There was no other palpable mass in the abdomen. Hernial orifices are intact. External genitalia, both the testes are palpable and normal in position. The right flank was full, sir, and then the left flank was free. There was no renal angle tenderness, and there was no palpable left supraclavicular lymphadenopathy. On percussion, there was dull note heard over the mass, and also right flank was dull to percuss, and the rest of the abdomen was tympanic on percussion. Coming to the auscultation, bowel sounds were heard. On digital rectal examination, there was no mass palpated bidigitally, or there was no anterior bulge, and the mucosa was normal. There was no other rectal growth. There was no active bleeding or no melena. On proctoscopy, there was no hemorrhoids. Other system, respiratory system, bilateral vesicular breath sounds were heard and air entry was equal on both sides. There was no added sounds. And cardiovascular system, S1, S2 heard, but there was no murmurs. Coming to the summary at the end of the examination, 38-year-old male, tobacco chewer, farmer by occupation, presented with complaints of mass in the lower abdomen since 2 months with history of umbilical discharge with increased frequency of micturition with no altered bowel habits. On examination, mass of size 20 cross 15 centimeters, occupying right iliac fossa, hypogastrium, left iliac fossa, umbilical and right and left lumbar region, with the lower border could not be made out with restricted horizontal mobility and hardened consistency. I would like to think of probably a malignant tumor of retroperitoneal origin, or it might be a chance of exophytic lesion also from the right side colon.
What are the 2 surgeries which are done where the incision is showed in the abdomen?
Sir, one was the right inguinal repair, hernial repair, sir. And
only
another one
surgery.
was, sorry, sir?
Only one surgery?
No, sir. Another one was actually, he had undergone true cut biopsy, sir, before he came here.
Okay.
Actually, why do you say it's a retroperitoneal tumor on examination? What are the points in favor of a retroperitoneal tumor origin?
Ma'am, one is the size of the mass, ma'am, and also which was with a restricted mobility, and also which is present on either side of the midline with the hardened consistency.
So you will expecting a retroperitoneal tumor to cross the midline, no?
Not always, sir.
So you are saying this anterior axial line to the another side anterior axial line, it is going.
Yes, sir.
But it does not compressing any vessels. This is such a large tumor. It is not producing any impact on the retroperitoneal structures.
Ajit, I have one question to you. Why did you consider malignancy in this patient? First, we'll come to that, and then anatomically try to put it somewhere in the. There's no GATs involved, so we know it's probably not from the GI tract, probably. So only 2 things are remaining now for you. Pancreas will not come there, so you are left with the urinary tract and the retroperitoneal.
Yes, sir.
So there is, I think, as far as that is concerned, we'll come to that. But why did you think of malignancy?
Sir, with respect to the history, it was a rapidly progressive mass, and then it was a huge mass, sir, of 20 cross 15 centimeters. And
that is why I asked you this question. What are the other masses can be huge, like what you mentioned, which can be benign, which can also grow to a large extent, which can feel hard. Like, yes. Yes. Tense.
Benign lesion, sir.
Yes. I am talking about benign lesion, very large one. Tense intra-abdominal cysts also can feel a hard sensation, deep seated. Okay. It has got restricted mobility. How to explain for a benign lesion? Suppose I ask you this question: restricted mobility.
Because of the size of the mass, sir.
You showed me that picture, video, but some important one finding you have told me on the right side.
Yes, sir. What? I couldn't insinuate the fingers, sir.
See, for the lower border, we don't use the word insinuation. You understand? We say lower border cannot be made out. That means it is going into the pelvis. Probably the restricted mobility can be explained because of that finding. The bones are coming. Insinuation is better used for only upper abdomen.
Yes,
it's a lower abdominal mass.
Yes, sir.
Right? So it's a lower abdominal mass, very large mass, restricted mobility, hard in consistency. Based on this, you see, I will consider malignancy. I have nothing against that. But also, if the question is asked, what are the other large abdominal masses. If they ask you, tense. What is the age of the patient?
So 38-year-old, sir.
38-year-old. So very large cyst with the hemorrhage can attain a large size, can grow like this, you see,
Yes,
and can feel hard. Feeling. You understand? So,
yes, sir.
Right.
Did you do a leg raising test in this patient?
Yes, sir. I did it, sir. And
What
it was
the
actually
finding of that?
there's no changes noted, sir.
And did he demonstrate any thrill in this lump? Did he like to demonstrate a thrill in the lump?
Thrill? No, I didn't check it, sir.
You know, what are the various lumps in the abdomen where you can find a thrill? So you percuss from one side and you can feel the thrill on the other side.
Once the tense mesenteric cyst, sir.
Okay, one is mesenteric cyst, yes.
In females, ovarian cyst, sir.
Yes, in the females ovarian cyst, yes. And cystic ascites. Okay, you can get the thrill in cystic ascites. In a case of hydronephrosis, you can get a thrill.
Okay, sir.
In a hydrated cyst, you can get a thrill.
Hydrated cyst, no, sir.
Now, in case if you get a varicose veins in this patient, what type of the varicose vein it will be? What type of the varicose vein it will be?
It will be secondary to the mass, sir.
The secondary varicose veins. No?
Yes, sir.
Yeah. Okay. So why did you keep a retroperitoneal tumor here as a first diagnosis?
Sir, one thing, because of there's no.
How do you explain the hematuria in a retroperitoneal tumor?
Sir, probably it might be infiltrating the bladder, sir.
You know, hematuria is a very important complaint in your patient.
Sir, but actually he had only
so
two
you
episodes,
have to you have to relate. Yeah, even if there are 2 episodes, that is not normal.
Yes, sir.
So you have to correlate something with a hematuria along with a big lump. So why not it's a bladder carcinoma as a first diagnosis?
Sir,
why a retroperitoneal tumor as a first diagnosis?
So one is the age, sir. Age is against the.
How does the age will?
Usually more than 50 years. And there will be
not a good criteria to differentiate here.
Yes, sir. And if it was a bladder mass, probably you would have had a continuous hematuria, sir. One thing. And I think it's less likely to grow to such a.
No, so explain the hematuria in this patient by the retroperitoneal mass. Now you have to explain the hematuria in this patient by any reason. Whatever you say, you have to tell the cause that why the patient had the hematuria.
I feel it could be due to infiltration of the bladder, sir.
Okay, so that is one reason, yes. Okay. Has this patient been investigated?
Yes, sir.
Yeah, go ahead with the investigation.
Tell the investigation.
Yes, sir. Sir, I would like to get the USG abdomen, sir, abdomen pelvis.
Tell about that ultrasound.
Shall I read the report, sir?
Yeah.
Yes.
Tell the salient points. Yeah.
Yes, sir. There was a large, well-defined heterogeneous hyperechoic intra-abdominal mass lesion measuring 18.7 cross 8.9 cross 14.4 centimeters. Noted that the level of umbilicus inferiorly abutting the urinary bladder wall, laterally on both the sides, displacing small bowel loops, posteriorly abutting the IVC aorta, and also anteriorly abutting the anterior abdominal wall. Lesion is showing internal color uptake on Doppler with a few hypoechoic cystic or necrotic areas, and there were no calcifications. And there was a liver was normal, and there was a left renal calculus.
So, what was the impression?
Sir, they thought it's a intra-abdominal tumor, probably desmoid or lymphoma, sir. That's what the impression was given.
And do you think the renal calculus is the cause of hematuria here? The patient had a left renal calculus. Do you think that is the cause for the hematuria?
Sir, probably, sir, but more of yes, sir.
You have continuous hematuria. Will the renal calculus produce a continuous hematuria?
No, sir.
That's stream. So I don't think you can attribute the hematuria to the renal calculus here.
Okay.
Yes. Okay.
Did they say where this lump is arising from?
No, not exactly, sir. They just mentioned intra-abdominal mass lesion. That's it.
What was its relationship with the anterior abdominal wall?
Sir, it is already abutting the anterior abdominal wall, sir.
Anything relation with the bowel?
Sorry, sir.
Intestines.
It was only displaced, sir.
What about the mesentery?
There's no comment about the mesentery, sir.
Okay.
Okay, go ahead. Next.
So
sir,
if you look at this ultrasound finding,
yes,
it is posteriorly abutting the IVC aorta. That means obviously
yes,
it looks like it is coming from that posteriorly from the mesentery itself, coming out as a large tumor. So obviously it looks like with this finding, it is looking like a retroperitoneal tumor only. With this, imagine this loops have been pushed posteriorly IVC aorta, and all the things are there. And I don't know to explain, but probably he has written there abutting the urinary bladder, whether patient had a cystitis and one sort of inflammation, that burning and frequency of micturition. He was talking about burning and frequency. Irritation would have produced 1 or 2 at hematuria, probably. A stone is unlikely to cause hematuria, as rightly has been pointed out. Please go ahead.
Okay, sir. So I would like to get a CCT abdomen and pelvis, sir. Shall I go ahead, sir?
Show the images. Show the CT.
So I have a video of the CCT abdomen.
stop the video in that one particular place where to see the kidney, and in that that area you stop somewhere in between. At least some more move large. Go ahead. Forward. Yes. Go ahead.
Still, sir.
Some more. Yeah.
Sir, I have a CT films photos pics also, sir.
Do you have picture of other sections?
Yes, sir.
Coronal and sagittal.
Yes, sir. I have, sir. Shall I proceed, sir?
Yeah, go ahead.
This was the transverse section, sir.
This is called axial section.
Yes, sir. I have.
Not transverse, but axial sections. Yeah.
Yes, sir. Yes.
What is this section known as?
Sir, this is the coronal section, sir.
Yeah. Any sagittal section?
Sorry, sir. I don't have a sagittal section, sir.
Okay. Did they report it arising from bladder wall?
Sorry, sir.
What is the report? Did they report it arising from bladder wall?
No, sir. They reported likely from retroperitoneum, sir.
Okay.
Shall I read out the report, sir?
Show the report, no?
Yes, sir. So report says there's a large ill-defined heterogeneously enhancing lesion seen in the lower abdomen and pelvis, predominantly on the right side, extending to the midline, likely arising from the retroperitoneum, measuring of 18 × 9 × 16 centimeter in size, heterogeneous enhancement on CCT with a few areas of necrosis, and the lesion is anterolaterally abutting the anterior abdominal wall with ill-defined fat planes, and inferiorly in flush with the anterior and right lateral wall of the urinary bladder with ill-defined fat planes. And medially, the lesion is displacing the small bowel loops to the left side. Posteriorly, the lesion is in flush with the ascending colon, sigmoid colon, right iliac vessels, and right psoas muscle. The lesion is causing mass effect over the right ureter, resulting in the proximal mild hydroureter nephrosis. There is a few calcified foci noted in the left adrenal gland, and there is a few tiny calculi of 2 to 3 mm noted in both the kidneys. And it was with a minimal ascites. CCT chest was normal, sir. The impression was large ill-defined retroperitoneal neoplasm with extensions as described, right mild hydronephrosis with bilateral clicker and mild minimal ascites.
Yeah,
So what are the...
Yes, ma'am. Yes, sir.
Yeah. Looking at the CT picture of the neoplasm,
yes, ma'am.
Looking at its morphology,
yes, ma'am.
What do you feel the lesion is? The tumor is?
Probably sarcoma, ma'am.
Why do you say it's a sarcoma?
It's a heterogeneous lesion with
Why don't you systematically describe it? Is it single or it is multilobulated? How is the consistency heterogeneous in nature or not? Areas of cystic spaces seen? Then you'll come to a conclusion. Probably not one, maybe more than one.
Yes,
2, 3. right? Yeah.
Yes,
So systematically describe your CT finding.
So it was a single mass, sir. Single mass with a heterogeneously enhanced lesion on CCT.
Please go back to the CT picture. Go back to the CT picture.
Go
Keep
to
it
the
in front
CT
of you.
picture. Yes.
Yes, sir. So in this coronal sections, we can see a single mass, which is heterogeneously enhanced on CCT with a few areas of necrosis, which we can see here, and it is in flush with the right side of the bladder, sir.
Vijit,
Yes,
consider
sir.
all the pictures. Start from above. So you'll be able to see various sections, isn't it? That will describe
Yes,
the lump much better.
Yes, sir.
Comes, yeah. Start from this above. Yeah. First
yes.
row of. Not there. Fourth picture, yeah.
Yes, sir. Yes, sir. So this was the again a single lesion with heterogeneously enhanced with normal bowel loops are seen, sir. There are few necrotic areas are noted here. Again, displaced bowels and in close in flush or in flush with the bladder. Reaching up to
picture.
the pelvis.
If you look
Yes,
at this picture,
yes,
is it single or the multiple lobulated areas are seen?
I feel
what
single.
I'm trying to point out is it can it be a lymphoma from this picture? Can it be a sarcoma? Can it be a cyst? There's a possibilities, isn't it? Very aged tumors.
Yes, sir.
Sujit, if you want to rule out between a sarcoma and a lymphoma, what structure you should particularly look for? That give you an idea whether it is a lymphoma or a sarcoma.
I want to look for other lymph nodes also, ma'am.
No, that's what lymph nodes. What are you particularly seeing? The encasement of the vessels you see more in lymphoma or in sarcoma?
Lymphoma.
So are the vessels paired here or not?
It's paired, ma'am.
Is it abutting or it is encasing the lymphomas or the
no.
vessels are getting lifted? Is it like that? You please show where it is.
Yes, ma'am. Here the vessels are just abutting, ma'am. The IVC is getting just abutted. It's not encased here, ma'am.
So that goes in favor of lymphoma or against lymphoma?
Against lymphoma, ma'am.
So you should tell those findings, no?
Yes.
So, so we have a large solid, looks like a solid tumor with the necrotic area. So
yes,
it's most probably a retroperitoneal tumor.
Yes, sir.
And as rightly has been pointed out as a differential diagnosis, already clarification has been given. So lymphoma to attain such a large size is, very unlikely. Not that it cannot happen, but you would have got some parietal nodes or iliac nodes or something like that. But in medicine, there's nothing like it is, impossible. So stromal tumor, if this question is asked, what answer you will give? Suppose this, you mentioned, no, whenever
yes,
a large tumor is there, bossylated, like, that large 2, 3. So stromal tumor, just what answer you will give?
Sir, it would be a well capsulated mass, sir.
This also looks like capsulated.
It's like capsulated only.
See that? The gist also will have necrosis. Gist can also occur in any part for that matter. It was written right or left. You can get arising from the colon also, intestine also, anywhere there, even though it is not the common site. You understand?
Yes, sir.
So but it is going into the pelvis, correct? On the right
Yes, sir.
side.
Yes, sir.
So when the examiner asks you, you only answer expected is gist can attain such a large size. That is the only thing you can expect. Gists are very well known for a large size, but no bowel symptoms. Not necessary. They grow extra luminous.
Yes, sir. Except right.
So
even they can arise from mesentery also. Right?
Yes.
The root of the mesentery is notorious for arising gist.
Yes, sir.
Where you can get such a large tumor displacing all the bowel loops and also not involving the great vessels.
Okay, sir.
Right? And it remains there for a good amount of time till it becomes visible because it's coming more posteriorly.
Yes, sir.
And that's why it attains a huge size and variegated appearance. It's a very classic picture of finding in gist that you get areas of heterogeneity. Right?
Okay, sir.
So what will you do?
So before proceeding, I just want to tell postgraduate, when they ask you on the initial part of the history, you said horseshoe kidney. Please remember, anomalies are rare.
Yes, sir.
Anomalies are rare, and a pathology arising from an anomaly is still uncommon. So you should understand. Horseshoe kidney per se, such a large one will not be palpable.
Okay, sir.
Most common complication of a horseshoe kidney is hydronephrosis. That part is clear because of the ureteric angulation. You understand?
Yes, sir. Yes, sir.
So you would have probably just told retroperitoneal pathology, you would have told. And second is, as we have discussed, because the whole issue came because of the hematuria, I think a little bit attention diverted to bladder actually. Otherwise, you know, and that umbilical discharge. Umbilical discharge is totally different.
Totally is a mismatch.
Yes, sir.
Please go ahead.
Yes. Sir, with this imaging findings, I would like to confirm the diagnosis with histological diagnosis, sir, with true cut imaging guided true cut biopsy, sir.
Why? What is the purpose?
Sir, the mass is huge and it's already abutting the urinary bladder and also abutting the.
So are you justified in doing a true cut biopsy?
Yes, sir. Because I might not achieve a en bloc resection, sir. So I would like to first go for a histological diagnosis and then probably neoadjuvant therapy, sir.
Is the size decides that criteria, or you think you only everywhere you said abutting? So only issue was bladder. Whether you could have mentioned, I will do one cystoscopy and see whether any infiltration into the bladder. Ureter, the same time, cystoscopy can be used for a ureteric stenting also, especially on the right side. So I think this is how you probably can proceed, I suppose. So after
definitely with this larger vessels are spared, I think you cannot say that it's inoperable. Definitely you can go and do that surgery. But as far as said, the cystoscopy part and the ureteral stenting can be done as a precautionary measure.
Okay, sir.
So maybe it is right, we can do a true cut, but in the examination part, do not come and say that true cut biopsy as the first you are going to do for a operable lesion. Only when you think that it is totally inoperable, you are going for a chemotherapy or secondary adjunct therapy, you are justified in doing a true cut biopsy.
Okay,
you said you did a CT of the chest also.
Yes, sir.
Yeah, what is the finding there?
It was normal, sir.
Okay.
So adding on to what Dr. Jailal sir said just now, related to your case, yes, very large one, inoperable, and strong suspicion of lymphoma if it is there, or strong suspicion of even GIST if it is there. This candidate will go for a preoperative imatinib if it is proved like that. So that is what I think you just need to talk in the examination when the examiner asks you. No? Otherwise, if it is operable, generally they are true cut is not done generally.
Yes.
What has been done to your patient? You tell first.
Sir, true cut biopsy has been done, sir.
What are the dangers of true cut biopsy, or what are the complications?
Sir, injury to the vessel, sir.
Firstly, you should tell me, you should always use the word guided true cut biopsy. You understand?
Yes, sir.
So you don't have, after the CT scan has been done, now you can use the ultrasound guided true cut biopsy in this patient. Understand? Then,
yes, sir.
Vessel's not a problem because IVC is quite posterior. No, you will not get into injury.
Yes, sir.
So bleeding, bleeding, yes, so bleeding, and most importantly, tumor spillage.
Tumor seeding.
Right now, you are doing a true cut. So these are the two. Bowel has to be, obviously bowel has been displaced. That's why you always use the word guided biopsy, right?
Okay.
These are the two complications. It can cause a hemorrhage. It can cause a hemorrhage.
Yes,
very vascular tumors, hemangiopericytoma, sarcomas, etc. They can really bleed because these are the tumors which grow large size because it might have drawn so much vasculature from the adjacent vessel, including the aorta, iliac, etc.
Yes,
as it is going down into the pelvis, a lot of new vessels would have come from these vessels, and it has become vascular also, right? Okay.
Yes, sir.
You should know that these are the complications can happen after a true cut. Yes, please go ahead.
Sir, true cut biopsy report shows microscopic section studied shows tumor tissue composed mainly spindle cells arranged in interlacing bundles, sheets, and vesicles. Cells have vesicular nuclei and moderate amount of cytoplasm and indistinct cell borders. Occasional mitotic figures are seen. Background is dense collagen stroma. Impression is feature suggestive of gastrointestinal tumor. Yes, sir.
They have advised IHC, right?
Yes, sir.
What IHC you would like to do?
Sir, in this case with the GIST, I would like to do CD34, CD117, and S100, sir.
Okay, in 10%, these are negative.
Sorry, sir?
In 10% of cases, these are negative.
Yes, sir.
Yeah. Is there anything else which you can do? What other things? They are suggesting it's a gastrointestinal tumor.
Yes, sir.
What other tumors it mimics actually? The ISCs, a panel of ISCs which you need to do, isn't it?
Yes, sir.
Are you doing 34? CD34?
Yes, sir.
You're doing CD34?
Yes, sir.
What is the reason why you're doing CD34?
Sir, that's a marker for c-kit, sir.
That is 117. CD34 is a marker of a vascular marker, right?
Yes, sir.
And endothelin or vascular marker, CD34.
Yes, sir.
CD117 is the c-kit marker.
C-kit.
Okay.
With that very few mitotic figure, no?
Yes, sir.
So you're thinking in terms of benign or malignant digest?
It's probably benign, sir.
So how you are going to proceed?
Sir, if it is since it's a gastrointestinal tumor, I would like to go with a surgical intervention, sir. I have to do en-bloc resection, sir.
So
such a massive size with the going into the pelvic. I would have probably, if there are no symptoms related to obstruction or bowel, probably role of imatinib has to be considered in this patient.
Okay. So yeah, absolutely. You know, sometimes it happens that when you resect such a huge tumor, because if the mesentery is involved, you may land up in excising a huge amount of gut also. Right? You'll not be able to actually get it out of the mesenteric leaf, the vessels which in the mesentery, and in the process you might lose a good amount of small bowel, right?
Yes,
It is always better to go ahead with the preoperative imatinib and see the response.
Yes,
Sunitinib.
Yes.
More than 10 centimeter size, 10 metatic figure. So all this we go for tyrosine kinase inhibitors, and then it is better to go.
Yes, sir. Okay, sir.
What has been done here?
Sir, no, sir. Actually, patient came just 4 days back, sir. He's not been intervened yet, sir. But, sir, we have got a IHC also done, sir. Actually, it's showing negative for S100, C34, and 117, with positive for Vimentin, SMA, and CD68.
What does it mean?
It is again going for
leiomyosarcoma, sir.
Leiomyosarcoma, yeah.
So much complicated.
So what is it from the bladder?
No.
No,
sir. There's no sarcoma from the bladder, unlikely.
What are the commonest tumor in the retroperitoneum?
Commonest tumor is
liposarcoma. What sarcoma is the commonest?
Liposarcoma.
Then?
And then even the leiomyosarcoma from the vessels, ma'am.
But here it is much away from the vessels, no?
Yes, sir.
Much away from the vessels.
Yes, sir. It's probably not from the vessels.
So now only way is surgery.
Yes.
Is it necessary that it must have the leiomyosarcoma will arise from the smooth muscle?
Leiomyosarcoma, yes, sir. From the smooth muscles.
What is the definition of sarcoma?
Sarcoma is a tumor arising from any of the mesenchymal tissues, sir.
So there is no need that it has to be arising only from the particular vessel. If there is, must be there. It can be differentiated. If this is undifferentiated tissue from the mesenchymal tissue, it can come when the tumor can differentiate into any type.
Okay, sir. Yes, sir.
Where do these retroperitoneal sarcoma metastasize most commonly?
So retroperitoneal initially to the lung, ma'am, and also to the liver.
It's the other way around. It's mostly to the liver and peritoneum, then to the lung.
Okay.
If it is a peripheral sarcoma, it will go to the lung first.
Lungs.
If it is abdominal sarcoma,
abdominal, it goes to.
Okay, sir.
How do you decide on the prognosis of these tumors?
Prognosis based on the grading of the tumor, ma'am.
Okay, can you throw more light on the grading of the tumor? How is it graded histologically?
Yes, ma'am. Grading is according to the grading which has G1, G2, and G3 grading, ma'am. Where it is the three components are considered. One is the differentiation of the tumor, ma'am. One is the amount of necrosis, and one is the number of mitosis, ma'am. Here with respect to
mitosis, what?
Per hyper
Number of mitosis?
per 10 hyper field, ma'am.
Per hyper field. Okay. How do you classify that?
Ma'am, actually, each of the component is given a score, ma'am. With respect to that, coming to differentiation, the first is differentiation of a normal mesenchymal tissue will have a score of 1, and the well differentiated will have a score of 2, and poorly differentiated will have a score of 3, ma'am. And coming to the amount of necrosis, if there is no necrosis, it is 0 score given. And then with respect to amount of necrosis, like if it is less than 50%, it is score of 1. And then if it is more than 50%, it is score of 2, ma'am. And coming to the number of mitosis, it is actually per 10 hyper field. If it is 0 to 9 mitosis is there with respect to 10 high power field, score of 1 is given. At the same time, if it is 10 to 19 per 10 high power field, it is score of 2, and more than 20, equal to 20 or more than 20, it is score of 3 is given, ma'am. Accordingly, once the score is given, with respect to G1, the score of 2 to 3 is G1, ma'am. G1, and then the G2 is
G1 is basically well differentiated.
Yes, ma'am. And then G2 is 4 to 8, ma'am. And then G3 is more than 9, ma'am.
So since you already done an biopsy, truncal biopsy, so will you go for direct surgery or upfront surgery, or you go for a chemotherapy, neoadjuvant therapy?
Sir, in this case with a huge mass, since neoadjuvant therapy doesn't help much, sir, I would like to go ahead with resection, sir.
Since there's no encasement, I think you will be able to do the resection also, complete the resection.
Yes, sir.
It's a very low Ki-67, right?
Yes, sir.
Yeah, so it's a favorable tumor, right?
Yes, sir.
And it is margins are well demarcated also.
Yes, sir.
The only concern is that whether the small bowel becomes sacrificed if it is arising from the retroperitoneum of the, the root of the mesentery.
Yes, sir.
Okay.
Okay, good.
Thank you, sir.
See, what you have to always keep in mind is, in clinical case presentation, the examiner will not be always interested in the diagnosis, how accurate you are in the diagnosis. Okay.
Yes, sir.
The more expectation is that whatever you are saying, you have to justify it on the findings, history, and overall picture, right?
Okay.
So, yeah, abdomen is a Pandora's box, right? So anything can come out of it. But whatever you say, you have to justify it with the available data which you have, right?
Okay.
Yeah. Good. Well done.
Thank you, sir.
Only, but for the umbilical discharge, that you have created some confusion. That
I think you purposely created that confusion, or what?
No, sir. Actually,
you have to divert the attention.
No, sir. I want to present whatever the history patient gave, sir. That's
see, you must remember one thing. Patient keeps on saying so many things. If you ask the patient, if you allow the patient to say the history, keep on saying how many cows, buffaloes he has in his home also, isn't it? So it is up to you to choose the right information and present in such a way that it brings to a conclusion, right?
Okay, sir.
Isn't it? So that is
Yes,
what
sir.
is expected when you are a good presentation is one which actually draws the attention towards, if not one, at least 2, 3 possibilities, and then you investigate. Then you actually invite more questions on investigations and all those things. So you
Yes,
get
sir.
more marks. You are actually generating marks there.
Yes,
Okay.
sir. Yes,
Yeah. So suddenly, if you say something which doesn't fit well, right, and then you cannot justify that thing because it is expected that whatever you are going to say should fit in one go. I mean, you cannot have 2, 3. It's not a good thing to have 2, 3 possibilities as far as the pathology is concerned.
Yes.
Most of the clinical cases are usually expected that you should have fit them in one pathology, right? So you need to know what exactly you have to, like in that way, right?
Yes.
Yeah, good case.
Do you have any questions, Dr. Sujit?
It was a good case, but
yes, sir.
Sir, Kanna sir, please.
Hello.
Yes, sir.
Recently, only about a week back, we had a similar case where the patient presented with the umbilical discharge, the hematuria, and lump in the lower abdomen, and this was a case of urethral carcinoma.
Yeah.
So I think one should not hide all those things. It has to be for the discussion purpose. Even if there is a umbilical discharge is there, I think it is not good to hide that. If there is hematuria is there, it is not good to hide that.
Yes.
Because if the examiner finds out later on from the patient or something happens, then it gives definitely a very wrong impression. So whatever his thing is there, the student has to present, and then he has to justify that. Okay, the justification is the most important thing. That you have to justify all those things, that why it can be there. You can say simply omphalitis is there. The patient, okay, somebody can have the omphalitis, it can be cause for the umbilical discharge. Okay, the patient may have a hematuria. In this patient, the hematuria may be because there is abetting is there, so there will be congestion of the bladder wall will be there because of this tumor which is there, and only that congestion which is there on the bladder wall because that abetting may cause the hematuria in this patient there. Though there may be no direct infiltration may be there, but because the compression of the vessels there, and because I think the cystoscopy is a very important thing which should be done in this patient to see further what is happening to the bladder there.
Okay.
But
so do you have any
you did a good
sir?
job. Yeah.
Thank you, sir.
Thank you, sir. Sorry, sir.
Do you have any doubts to be clarified or any questions?
No, sir.
Thank you, faculty. Guru Shantapa, sir, your comment, sir.
Sir is not there.
Sir is not there. Okay, sir. Okay.
So credit goes to Shilpa ma'am.
It is Shilpa ma'am's PG, right?
Yeah.
Thank you, ma'am. Thank you for preparing your PG so well for this forum. We look forward you to join us and the PGs also to be part of us in the future program.
Yes, sir. Thank you so much.
Thank you very much, Somprakash sir. Thank you very much, all our faculty, Dr. Kanna sir, Raj Gopal sir, Jailal sir. I could see Rajiv Sahai sir also. It's been quite all through. And Somprakash sir, we have been repeatedly troubling you. I'm sure I'm going to pull you up for more classes.
Yeah, no problem. But Dr. Rajiv was very quiet today. I don't know why.
Unusually quiet. Unusually quiet.
A lot of questions being asked. So
Thank you very much, sir. And I would also welcome PGs from other underrepresented areas to present cases here. And any of the senior faculty of your professors are interested, just leave a private message to me. I will personally call up and invite them. So I thank all of you for joining this evening. So we look forward to meet you in yet another session coming week. Thank you very much. Good night to all of you.
Good night.
Thank you, sir.